Fifth metatarsal fractures. A good classification would be Stewart. There are 5 different categorizations depending on the location and the age. This is obviously clearly seen the gapping in between the metaphyseal as well as the styloid. The literature does talk about fixating these surgically, and today the literature concentrates on intermedullary screws. That would be a screw that goes from the base, which is right from here, goes all the way inwards, and has to be the threads have to be abutting the cortex to have some grab to it. So it is basically a compression modality which is utilized and preferable in the literature in comparison to the previous thoughts of using plates and screws. Lag screw phenomenon, which is a screw goes perpendicular to the fracture site and creates compression. And then there's the tension band wire technique, which is adapted from the olecranon, which is the elbow, and that utilizes the pull of the tendons in the area to create compression. So these are options from a surgical standpoint. One day I would like to publish, if I could, the case study that would exceed over 100 of these fractures that clearly show proper immobilization. It does work phenomenal, and it varies on the gender, the age of the person, and the severity of the fracture. Sometimes there are comminuted fractures, multiple fractures, that require slightly longer, and hopefully in the future I will show you all of these. So I just wanted to show you a fracture, and as we clearly can see, the gapping still is shown on either side, and again, it's repeated over. This just underwent cast immobilization, and we will show you the result. So this person underwent, I believe, a total of 9 weeks of immobilization. Some people do have concerns because of the blood clots or atrophy, but as we can tell clearly, the cortex, which is the shell of the bone, sealed very well. There is no, we'll look at all these views to compare. Everything is solid. That little discoloration is the remaining blood that will continue to calcify. As we look at it from this angle, we can still see also the blackness or the circle discoloration. We call it radiolucency, but we see fuzz more inside, which is migration of calcium phosphates. It's obviously healed and sealed. Looking at it from this angle, it's totally healed without any displacement or angulation of the bone. So as we look at it from also all these views, and we're looking at it from here as we saw to compare it with the other one as well, it's phenomenal. So at some point you got to understand the ramifications of fixation. You still got to cut the person open. The risk of infection is still there. It still requires 4 to 6 weeks of immobilization with hardware. So one would question themselves at some point, say, why am I getting myself risk of infection, lack of non-union or healing issues to the bone or to the skin? So those are extreme interesting questions that should be addressed. And again, I've been in practice for a long time. I have done my fair share of fixating all the types of metatarsals with the Lord's blessing, very successful. But at times you want to start thinking, as we get older, what is the least and the best for the patient. And I think at this situation, especially the fifth metatarsal, maybe somebody has to relook at the history, the current data that clearly shows that immobilization is actually very beneficial. When I was in school, they used to teach us the fifth metatarsal has poor blood supply, It has excessive independent motion due to the intrinsic muscles of the foot. The extrinsic muscle attachment, which is the tendons that come from the leg into the pull of that bone where my cursor's at, all that weaken the healing potential, as if you're trying to glue something and constantly moving it. And that was how we was ingrained into our heads. So therefore, you see these fractures fixate immediately surgically. And hopefully in the future as well, I will show you several, well over dozens of ankle fractures as well that heal phenomenal with immobilization as well. I'm not saying that immobilization is the answer to all the broken bones, but at times it should be considered, and understand the pros and the cons of both. So as we look at it, obviously it is totally healed, and at some point, hopefully, I will present all these cases to show that there is a significant improvement with cast immobilization, no metal, no irritation. And to understand one more tidbit that I did not explain, to address this surgically before from a plate and screws requires a long cut along the top part and side of your foot, which some people do create scars. There is still plate that rubs with the shoes, so there are nerves in the area for entrapment. There is something called the cicatrix, which is a entrapped pathological nerve due to scar tissue formation. There's quite a few things that need to be addressed. Disregard the irritation from the hardware. So versus the small incision that now there are talking about, which is the intermedullary screw, which is a little screw that goes inside with a little tiny slit from the rear, and it goes into the medulla, and the threads have to be the same as the width of this. You will feel the grab, and it works fairly well if needed, if the gap is too great. But I will show you guys in the future that there are much worse cases that have clearly shown comminution, which is complete, as if a grenade went into the bone and shattered it into 5+ pieces. And theoretically, you can't do much for that. Going in, getting the fragments, other than pinning them or wiring them, there's not much you can do. You can try to put some kind of a clover plate and bone graft it, but again, if you allow it to consolidate, the body does miracles. And so, yes, I was surgically trained. Yes, I am a foot and ankle surgeon. However, at times you got to sit back and say what is best for the patient, and do such. Thank you very much. Hopefully that helps you guys who have fifth metatarsal fractures, and try to get an understanding.